Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology and Urology at Seoul National University Hospital. In this session, I would like to share my experience of how we can differentiate the small solid renal tumors by using a pattern recognition approach. With improvements of imaging techniques, more and more cases of small renal tumors are detected. What is the criterion of small in small renal masses? Many old articles dealt masses smaller than 3 cm in diameter, but recent articles use 4 cm criterion, probably because 4 cm is also a criterion of stage T1A renal cell carcinoma. One important fact in small renal masses is that significant proportions of removed small renal masses is benign. According to these articles, approximately 20% of removed small renal masses are benign. Among malignant lesions, about 6% are indolent cancers and only 20% are potentially aggressive cancers. Because of this relatively indolent nature of small renal masses, in addition to surgery and thermal ablation, now active surveillance has been recognized as an appropriate strategy by both European Association of Urology and the American Urological Association. So, the role of imaging in small renal masses is, first, detection, and second, characterization, most importantly, differentiation among renal cell carcinoma, fat-poor angiomyolipoma, and oncocytoma. And if the mass is likely a renal cell carcinoma, then prediction of histologic subtype. In other words, role of imaging is to distinguish high-risk versus low-risk small renal masses that may influence clinical decisions and patient outcome. Imaging patterns or parameters we may use for these characterizations are echogenicity at grayscale ultrasound, flow signals at Doppler ultrasound, attenuation at non-enhanced CT, MRI signal intensity, enhancement pattern at contrast-enhanced CT, MRI, or ultrasound, and some other patterns. Let's start with ultrasound. It is well known that angiomyolipomas are typically hyperechoic, but 1/3 to 1/2 of small renal cell carcinomas are also hyperechoic, so we need differentiation. Usually angiomyolipomas are more hyperechoic and usually show some degree of posterior sonic attenuation, while renal cell carcinomas are less hyperechoic than angiomyolipomas and often accompany hypoechoic rim and intratumoral cysts as this case. Here are 2 hyperechoic renal masses of similar size. One is renal cell carcinoma and the other is angiomyolipoma. You can easily tell which one is which if we recognize posterior sonic attenuation and poorly demarcated posterior margin of this mass. So this is angiomyolipoma and this is renal cell carcinoma. Long time ago, we had done a study of measuring relative echogenicity to differentiate small hyperechoic renal cell carcinoma from angiomyolipoma. We calculated relative echogenicity of a mass by assigning 0% to renal cortical echogenicity and 100% to renal sinus echogenicity. And we found that relative echogenicity of angiomyolipoma and renal cell carcinoma was well divided at 80%. It is quite simple to apply, and we can do this by measuring grayscale at PEX system at 3 points: renal cortex, renal sinus, and renal mass. This is a case of angiomyolipoma with 210% relative echogenicity, and this is a case of hyperechoic renal cell carcinoma with 63% relative echogenicity. Flow patterns of angiomyolipomas and renal cell carcinomas are different at Doppler ultrasound, and these differences were reported in these two articles with these schema. Angiomyolipomas usually show absent or just mottled flow signals, while renal cell carcinomas usually show prominent vessels in and around the mass. These are three different cases of angiomyolipoma, and these are three different cases of renal cell carcinoma showing different flow patterns. We can imagine that ultrasound elastography may be useful in differentiation between angiomyolipoma and renal cell carcinoma because angiomyolipomas are relatively soft and renal cell carcinomas are hard. In this article, they used 4 patterns from soft to hard and well showed different patterns between angiomyolipoma and renal cell carcinoma groups. Most angiomyolipomas showed pattern 1 or 2, while most of renal cell carcinoma showed pattern 3 or 4. These upper 2 masses were angiomyolipomas, and the lower 2 were renal cell carcinomas. Now let's move on to CT attenuation. Hounsfield unit at non-enhanced CT is a simple parameter to make a diagnosis of angiomyolipoma. If we see a mass with gross amount of fat, the diagnosis of angiomyolipoma is straightforward. If it is not clear but suspicious, we may use Hounsfield unit mapping, and if there are clusters of negative value pixels, also we can make a diagnosis of angiomyolipoma. There was an article showing the value of counting the negative attenuation pixels for diagnosis of angiomyolipoma, and they reported 100% specificity and positive predictive value for angiomyolipoma if there are more than 20 pixels of lower than -20 Hounsfield unit or more than 5 pixels of lower than -30 Hounsfield unit. These 2 articles were published in the same year 2008 in the same journal, Radiology, using CT histogram analysis and pixel distribution analysis. Both are basically same techniques to differentiate fat-poor angiomyolipoma from renal cell carcinoma. One study set may be useful, while the other set cannot be used for this differentiation. I do not think this is a practically useful method for this differentiation. There is a concept of dangerous Hounsfield unit zone at non-enhanced CT for renal masses. These 2 articles reported this concept, and Hounsfield unit between 20 and 70 was a dangerous zone. It means that if Hounsfield unit of a renal mass is lower than 20, or higher than 70, we do not need to worry about malignancy, but we should be careful if it is between 20 and 70. A renal mass of lower than 20 Hounsfield unit will be a benign cyst or angiomyolipoma, while a mass with higher than 70 Hounsfield unit will be a benign hemorrhagic cyst. This mass, Hounsfield unit almost 0, a simple cortical cyst. This mass, Hounsfield unit around 100, a benign hemorrhagic cyst, and this mass around 40, a clear cell renal cell carcinoma. Here are 2 renal cell carcinomas, one clear cell type and the other papillary type, with CT attenuations of both masses within dangerous zone. We should be careful if the mass has heterogeneous attenuation. This is such a case, a mass with heterogeneous high attenuation. Very high attenuation 120 with maximum 144 and minimum 100, well outside of dangerous zone. But contrast enhanced CT and MRI with subtraction will show enhancement of central less high attenuated portion. It was a case of chromophobe type renal cell carcinoma. How about signal intensity at MRI? It is known that signal intensity at T2-weighted imaging is a useful parameter because of usual high signal intensity of clear cell venous carcinoma and low signal intensity of fat-poor angiomyolipoma. This is a case of biopsy-confirmed fat-poor angiomyolipoma. There was a nice and practical recommendation by Dr. Silverman. If there is a suspicion between renal cell carcinoma and fat-poor angiomyolipoma at CT, then do MRI and look at T2-weighted imaging. If it is of low signal intensity, it is probably fat-poor angiomyolipoma or possibly papillary renal cell carcinoma. And if it is of high signal intensity, it is probably a usual clear cell renal cell carcinoma, and the possibility of angiomyolipoma is very low. So do surgery if it shows high signal intensity, and do biopsy if it has low signal intensity. Left side was a case of fat-poor angiomyolipoma, and the right side was a case of clear cell renal cell carcinoma. Two different cases of fat-poor angiomyolipoma showing low signal intensity at T2-weighted imaging. But we should keep in mind that papillary renal cell carcinomas also show low signal intensity at T2-weighted images, as you see in these three different cases. Chemical shift MRI is another method we can use to differentiate angiomyolipoma from renal cell carcinoma. If a mass has macroscopic fat, as in classical angiomyolipoma, opposed phase image shows Indian ink or etching artifact like this case. But if a mass has a microscopic fat, as in fat-poor angiomyolipoma, or intracellular lipid, as in clear cell venous carcinoma, it shows more or less homogeneous signal drop at opposed phase imaging, like this case of clear cell venous carcinoma. This is a case of classical angiomyolipoma. CT shows areas of macroscopic fat, and opposed phase MR imaging shows typical Indian ink artifact. This is a case of fat-poor angiomyolipoma. CT shows no evidence of macroscopic fat, and opposed phase MR image shows small focal areas of homogeneous signal drop. These are three different cases of clear cell venous carcinoma showing areas of homogeneous signal drop at opposed phase MRI due to prominent intracellular lipid. How about diffusion-weighted imaging? Is it useful in differentiation of small renal masses? I think still we do not have a clear answer, but some articles reported value of diffusion-weighted images. This study showed the difference of ADC values among histologic subtypes of renal cell carcinomas, with the highest value in clear cell type and the lowest value in papillary type. This is clear cell venous carcinoma, and this is papillary venous carcinoma. You can see the difference in ADC map imaging. This was a patient with two renal masses in the same left kidney. This mass number 2 has lower ADC value than the mass number 1. This mass number 1 was clear cell venous carcinoma, and the mass number 2 was papillary venous carcinoma. How about enhancement pattern after contrast injection in contrast-enhanced CT, contrast-enhanced MRI, or contrast-enhanced ultrasound? Enhancement pattern is different among subtypes of renal cell carcinomas. With clear cell renal cell carcinoma, strongest enhancement and fast washout, papillary renal cell carcinoma, weakest and flat enhancement pattern, and chromophobe renal cell carcinoma in between. Enhancement pattern of oncocytoma is quite similar to that of clear cell renal cell carcinoma. Here is another article showing similar results. clear cell venous carcinoma and oncocytoma, strongest enhancement and fast washout. Papillary venous carcinoma, weakest flat enhancement pattern, and chromophobe venous carcinoma and angiomyolipoma in between and variable. Contrast-enhanced ultrasound is probably the most sensitive technique showing the presence of enhancement, which is a very important and critical finding in evaluation of a renal mass, especially when enhancement is not evident as CT or MRI, like this case. CT shows a renal mass with slightly high attenuated areas, and the enhancement is not definite. So this mass may be a hemorrhagic cyst, but also may be a cystic renal carcinoma with weakly enhancing solid portion. This differentiation is very important in this patient, and the contrast-enhanced ultrasound will be the best option for differentiation. Contrast-enhanced ultrasound well shows the presence of enhancement in this area, and it was a clear cell venous carcinoma. Of course, quantitative analysis is also possible from time intensity curve. Lastly, other patterns or parameters like shape and some internal architectural patterns such as stellate scar and segmental enhancement inversion may be helpful. Observation of certain shapes like ice cream cone or mushroom shape may provide useful clue to make a diagnosis of angiomyolipoma. You can see angiomyolipomas in these two patients having this ice cream cone or mushroom shape. Here are two more cases of fat-poor angiomyolipoma showing similar ice cream cone or mushroom shape that was helpful in making a correct diagnosis. Here are two renal masses of similar size and a similar enhancement pattern. One is renal carcinoma and the other is angiomyolipoma. If we consider the difference of shape, it will be easy to tell this is fat-poor angiomyolipoma and this is renal carcinoma. The finding of stellate scar or cartwheel appearance is known as a hallmark of oncocytoma, usually seen in large oncocytomas. But this finding can be seen in medium-sized or small-sized oncocytomas as well. One thing we should keep in mind with this finding is that we often see very similar findings in chromophobe renal carcinomas. Another interesting finding we can see in oncocytomas is so-called segmental enhancement inversion, published by our team in 2009 in Radiology. This is a case in that article, and we clearly see inversion of enhancement of these segments in early and late phase of contrast-enhanced CT. Another case of oncocytoma with same phenomenon, segmental enhancement inversion. Different cellularity probably explains the pathologic background of this phenomenon. After we published this phenomenon, there were subsequent articles regarding this phenomenon saying that this finding may not be a reliable or characteristic finding to make a diagnosis of oncocytoma because this finding was not common or characteristic in their oncocytoma cases. Our team continued to study on this subject and found that this finding is quite common in small oncocytomas and also may be useful in differentiation between small oncocytoma and small chromophobe renal carcinoma because this finding was seen in about 2/3 of small oncocytomas but was seen in only 7.3% of small chromophobe renal carcinomas. This is the summary of my talk. We can use various patterns or parameters of various imaging studies. No imaging pattern or parameter is perfect in characterization of small solid renal tumors, but I'm sure that we can improve it if we continue to try. Thank you for joining this session, and please email me if you have any questions.